this is really exciting. How many, most of people are here in one area, so how many are you involved in using data for looking at health and human resources? To look at data, other things, lots of folks. Okay. Not that you have personal involvement, but how many of you realize that law enforcement also uses data? And that in some ways has been using both individual and aggregate data for a long time, with very specific short-term outcomes that they're worried about. That it's not, oh, let's look at the data for 2 or 3 years and we'll figure out what's going on. They have a long track record and ways of using data, including across jurisdictions, because even though you may be talking about federal and city and state, there are often multiple jurisdictions operating in the same law enforcement. So I think we're really fortunate today to be able to hear some of the work that's being going on that has, again, a health interface that's on opioid things, but really helping us understand where are some of the opportunities, including the long-term doing this. And Captain Colon has been involved for almost 25 years in doing this work, both as an individual person and also as part of teams and processes for looking at data. So now, how many of you only wear one hat? Raise your hand if you wear only one hat. Okay, none of you. And I think so you're probably not laughing at all my multiple appointments, because you recognize to get things done, if you're not sort of legitimate within some other department, some other school, with some other agency, if you're not wearing multiple hats, the first question people are going to ask is, well, you don't understand us. What benefits are we going to be getting? And I think part of the interoperability is that many of us have really been crossing networks and other kind of things, and so that's really exciting. I think what we're trying to figure out, though, is not just what data do we need and how do we analyze the data, but how are we changing the built and social environments? And social environments involves prescription patterns. And causes of pain and illness and other things, and how to cope with these kind of things. Today we're going to be talking about for a couple of minutes around opioid overdoses and preventing deaths from overdoses. But it's really this general thing of, how do we make changes? And we've had this discussion now this morning. We had almost yesterday for several hours. It's not just the data we're trying to get a better handle in. That we really are interested in using the data to make change and coping with the fact that the data is in lots of different places. Now, this is just sort of a chart that, for years and years we've been monitoring homicides, not just in Baltimore, all sorts of crimes, deaths, low birth rates, other kind of things. And it's, sort of been aggregates. We've been doing it sort of at a policy level. What kind of things do we need to do? How do we improve services, access to services, or other things? And even because of the frequency, so one of the things that's existed for many years are assessments of infant homicides, deaths before 1 year. Some cases they've expanded it now to any sort of juvenile deaths. We moved to everybody under 18 who dies, where there's a formal review to try to figure out what could have been done to prevent the next death. Now, obviously, the person's died. We can't prevent that death. But what can we learn? Where are the patterns and other kind of things? We're trying to turn that around. And what we're doing with the opioid crises, as well as more general, is trying to take some of those strategies and apply it much more broadly, where there are many more deaths. Baltimore, even though we have one of the highest rates of homicides in the country, and actually in the world, we have more people dying from opioid overdoses and drug overdoses in Baltimore than we do from homicides. So that's a major issue, and part of what we've been looking around is the hospitals didn't realize that there's a lot of shootings and homicides just around the hospitals, and how people coming in. If you're sort of shot near one of these hospitals, they're not necessarily taking you to the tertiary care, the level 3 trauma center, if it's 3 or 4 blocks away from an emergency department where there are also surgeons. And so how do we respond to these things? What are we doing these things? Looking at some of the clusters, and I just use these data because these are data that we've aggregated, but that we actually collectively get in real time. And how many of you, I'm on a list server that whenever there's these incidences, I get notified. Within 3 miles of some place I've given to them, every single shooting, every single aggravated assault, I get a little text message that says, here's what it is, based, literally they're monitoring the police reports all the time. But we're not, again, how do we use these things? And so often we have some assets there that really aren't being used, and this is where my office is, and you can sort of see even around Johns Hopkins Hospital, we had 23 people shot and within a quarter mile. And more within a half. We're not even talking about huge differences. Now, when we look at some of the same things, and we're going to hear a little bit, the same thing is true with the opioid overdoses and the drug overdoses. Yes, they are occurring lots of different communities in every place, but they're not necessarily occurring on every single block. As well as you'll hear a little bit more about some of the other related issues around robberies and other things, that these are not individual things that we want to do. We want to be bringing these things together. And in the same way that we got involved with positive response around losses, and certainly when we're talking about overdoses, we have schools that have had 3 to 7 kids murdered in their school. And this is public schools. This is in a year period. Thinking about how to respond both to the families, the neighborhoods, as a way of trying to break these cycles, I think some of the lessons that we've learned from the violence prevention, the interruptions, that we haven't done too much for the drug users so much, are things that we can be doing. And then equally important, and potentially even more important, in Baltimore, we've had lots of drug overdoses. We've had lots of drug use, very high levels of drug use and heroin use for generations. One of the questions has been locally, they said, well, where are our services? What's going on? Why don't people care about us? And now that there's sort of an attention, those of you who have seen the newspaper in the last day or two, or maybe watched the TV shows, we're almost out of naloxone. We've given out so many drugs to be able to prevent overdoses. In Maryland, you don't need a prescription anymore to even get you can walk down and you can pick it up if you can pay for it. And the health department's distributed about 8,000, 10,000 doses to the point where they're literally almost out, and trying to figure out where are they going to get the money to get it out there, because again, our drug use is so high, and the need for this is so high. But again, this is also, there's a lot of people out there hurting. And part of the reason they're using the drugs is because they're hurting. So it's not just preventing them from dying, because even though we've prevented the death, they still have some very significant consequences if they overdosed in terms of their health and other kind of things. But again, getting them not to have to go to have to stay in the hospital for only a short period of time doesn't really break the cycles. And so we really need these multifaceted both data systems, but also responses, because each of us sitting around the room can probably only respond positively and effectively for one part of the solution. And so I think, as you're going to hear, bringing together these multifaceted collaborations, as you've heard already today, in terms of the regional and the state kind of things, to be able to bring these things together, but the easy things to do this. And it's how to do this in real time. So how many people in the room have heard of Freddie Gray? Freddie Gray was the young. Okay, so if you're looking at this sign, what's one of the things that you may be wondering about? It says, "Get well soon, Freddie Gray." Now, he died within a week of his police encounter. So obviously this was taken before he died. Not obviously, this was taken before he died. This was taken the day after he went into the hospital. He was actually on life support, but people didn't know he was on life support. And so the question may be, and so you probably saw the riots and the disturbances in Baltimore City up at North and Penn. Every one of the people in this picture actually knew Freddie Gray. Again, this is right after the incident. This is when his friends and neighbors were getting involved, and he was still alive. And so the question is, how did I, and many in the room are in the same place, what is our information system so that when these events take place, we are actually able to respond in real time, not after they blow up, not after they escalate, but to be able to get responses in real time. And I think obviously what Maryland, and particularly Baltimore, but Maryland in general, is doing around getting these drugs disseminated. And they even moved from, you used to have training to do it. to be able to get one of the prescriptions. And now they've eliminated that because the rates are so high and they really want to reduce the barriers to be able to save people's lives that they decided that's there. And one of the important things also is calling folks, because again, just because you've sort of injected somebody, again, doesn't mean they're walking away. Doesn't mean that they're in good health. The people who are probably in most contact may be doing some other things that are illegal, may not want, and so how do you create an environment where people will report when people will do those things, which again, we're working on in Baltimore. And so one last thing, or next, is, okay, so this was a basketball game, again, this was after Freddie Gray Drive. This was organized by the Bloods, Crips, and Black Guerrilla family. This was something to say, listen, this was after the riots had sort of started, there was no school this day, and they said, wait a second, if kids are not in school, we can't, these are my nieces and nephews, in some cases our children, we got to do something for them. And they were also getting a lot of bad press about what was going on. So I think so they literally organized this. They have some good contacts for bringing in some, it was funded by legal resources. But they organized this, and you can't tell from this picture, but they actually had played basketball with each other at times when they also are beefing to come together. And I think how to bring in the consumers, how to make sure that we're using the whole range of people that are important. And the last point is in the same way that we have some violence prevention efforts, and as many of you probably know, that Baltimore still is at an all-time high record rates of things. What we find is not everything works. So some of our interventions greatly reduced shootings in the neighborhoods that they were going on. Some of them actually made it worse. They disrupted the usual patterns of doing business so that people then sort of moved in, started shooting each other to be able to take over the business, or after the riots, very low cost, there was a lot of pharmacies that got broken into. So there was a lot of essentially no-cost drugs into the market because they didn't have to pay anything to rob the pharmacy. And then that created sort of disputes among the people that sort of thought they had a business in that area and had to sell the drugs for a certain level with people who could really undercut them because it was free. And so I think, again, as we're thinking about using data, using drugs, needing to involve a lot of different information in making these decisions, I think that the opioid epidemic and how it's being responded to across the country is a good example of things that people may have started a little bit earlier and building on some of the law enforcement activities, so they've been able to get things organized. But it has to also interface with prescriptions and how prescriptions are monitored and how you get doctors to change things differently. So this is not necessarily something that's easy to change. But I think, again, just looking at the people in the room and hearing earlier about what many people are doing, there's going to be some really good opportunities to sort of move things forward. So with that, I think we're going to then just introduce.
Thank you, Doctor. All right, good afternoon, everyone. All right, so I'm going to give you an overview of the Drug Monitoring Initiative, some of the data sets that we collect, give you an overview of fentanyl, the drug harm index. So for the next 6 hours, just kidding, a lot of material to cover in a short amount of time. But some of the stuff that you're going to see here, you already heard about. And seeing it as a trooper, in our Information Technology Bureau, and also what we encounter with the Department of Health, we see these data strategies being very, very heavy on the defensive side, trying to protect the data from being exposed on the physical side, on the technical side, and also through policies and regulations. But what I've been able to do with the Drug Monitoring Initiative is really exploit this data and really do the offensive strategy against data to do a lot more exploiting that data to get some value out of everything that we collect within law enforcement as well as health. So this is a map from the CDC indicating where heroin-related deaths are occurring throughout the country. We in New Jersey have not been spared. We've been dealing with this issue for quite a while. In fact, back in 2006, when I was first assigned to the Fusion Center, we experienced 103 deaths in the Camden and Philadelphia area, all attributed to fentanyl. And I had never heard of fentanyl. I really wasn't familiar with it, and the prosecutor's office came over to the Fusion Center asking myself and other troopers what is going on in the area. We really didn't know. Fast forwarding all the way up to 2009, we kept seeing that the number of violent crimes, the shootings in the urban centers, the number of burglaries that were occurring throughout the state, and also the high number of overdoses occurring were all being driven by heroin and opioids. Then in 2013, the State Commission of Investigations releases a report that we were, in fact, under an epidemic, and we were asked to start this drug intelligence capability, which we had already started. A little secret, we have 496 police departments, and even though I started to collect data from the police departments about drug seizures throughout the state, 496 police departments were not going to be cooperative. So what I did, I went to the 9 crime forensic labs throughout the state that know with empirical certainty what it is that's in those packets that were being submitted. So now I have true data that I can work with, and it's all, it was just a matter of taking the 9 lab directors, asking them to give me the same exact data elements. It used to be on a monthly basis. Now we get a data dump on a daily basis. So I just want to use that as the foundation for everything and the way things evolved and the data sharing agreements that we have. So we implemented this robust data intelligence capability to help us understand not just the supply side in law enforcement, but also the demand side. And the data helped us identify problem drugs in problem areas and also problem people, which enables us to also support investigations. Whenever spikes in overdoses occur, we're able also to help EMS deploy resources, surgically deploy those resources to those hard-hit areas. But most importantly, to me, the most important one here is enhancing the development of effective policies and practices. You really can't do that if you don't know the extent of the problem, right? So what gets us that understanding is truly the data that we collect. So you got to figure, myself having done undercover work, patrolling the turnpike and all the different highways, I come from that supply side. I want to lock people up. But coming in to the demand side, and going to the Department of Health and Human Services, they say, hey, look, you should become part of the state epidemiological outcomes work group. You want to share data with us? We're quite surprised that law enforcement wants to share data with us every single day as opposed to waiting 18 to 24 months. So they welcomed this with open arms. And they really brought the gentler kind of side of me, helping me understand that putting people behind bars isn't really the solution, that demand reduction is truly the key. So once we started collecting all this data, you look at the 2014 map, these are all the heroin seizures that occurred during 2014 compared to the 2015 map, where you see that proliferation from the urban centers to the suburban and rural areas of the state. The problem only continues to get worse in spite of all the different efforts that we have. Well, what data sets are we collecting? We're collecting from, again, the labs, DEA, the Department of Health, Human Services, McLaughlin, HIDA, all these different partners that are contributing data to us on a daily basis. We originally started with just heroin, but now we're collecting data on every single drug that hits all of the labs. This is what's being sent to us every single day. So not to get into some of the challenges, but we are data-rich, technology-poor. We have to clean all this data, normalize it, geocode it, and then map it to really give it some sense, make it have some meaning. We also correlate this data with shootings, gun recoveries, drug arrests. Every single day from the automated fingerprint system, we get a data dump for everyone who was arrested throughout the state. Because we're interested in drugs, we scrape it out by statute and do the same process for all that entire data set. Also, naloxone deployment, going back to the origins, as opposed to just collecting everything that was seized by law enforcement, I also wanted to know the Department of Health's activities when it came to administering naloxone. So I entered into a data use agreement with them. which took 9 months because of the lack of trust. They thought that we were going to go out and arrest people that were being administered naloxone. So it took a little while for them to be convinced that we weren't, in fact, going to use this for prosecutorial purposes, but to help understand what the problem was occurring. So you see law enforcement administering naloxone, you see EMS. That data set, and even now working with Jeff Beeson on developing a naloxone app, it's given us real-time understanding of where these hotspots are occurring. Toxicology data from the medical examiner's office. At first, we were rejected. When we said, you know what, even though you're saying no, you're not going to share, we put them on our distribution list. Anyone that said no, we still say yes to them, and we started to share information with them. And then in time, they came around, and now they're sharing death data with us, and in real time as possible as they can. Drug addiction treatment data. It is the only data set that comes out of a survey. Everything else that we use is empirical data, but all of these different data sets are just little pixels that really help paint the picture of what's going on. Children and families, 2 weeks ago, I finally met with them. We're going to be collecting neonatal abstinence syndrome data to find out where those infants that are being born exposed to substances, and then the others in red are those that we're still working on collecting. So just a little bit about New Jersey's drug environment. This is fentanyl, the last 4 quarters, 2015 through 2016, how it's just been increasing significantly. This is a daily report that we used to push out back in 2014, showing, and you compare it to what we see now in 2016, in 2017, how those in red are your fentanyl-related incidents, how they just increase exponentially. How did we get here? As you could see, prescribing practices leading to a higher number of deaths. And in New Jersey, this is what the death toll looks like, starting with 2010 all the way to 2016. But this only tells you one piece of the story. Collecting data from different partners, you could start to see what are the contributing factors, starting with pills and heroin, all the way up to 2013, and then in 2014, you see the introduction of naloxone having a slight impact on reducing the death toll. But then for the first time, one of our crime forensic labs identified fentanyl. Then in 2015, we also had acetylfentanyl, and then you see what happened to the numbers there. Fentanyl is really the killer in New Jersey and around the country. And then for last year, you see a couple of other fentanyl derivatives, parafluoroisobutylfentanyl, parafluorofentanyl, U47700, velorofentanyl. All of these different derivatives and other opioids are really contributing to the death toll in the state. And then already in 2017, we have tetrahydrofuranylfentanyl, and U477 has already been molecularly changed to U49900 and acrofentanyl. These are the new ones, new killers in the state that are really contributing to the death toll in New Jersey. So where are we headed? Started with pills, went to heroin, then fentanyl. Now, even though you're hearing about PDMP and all the doctors being regulated, the problem that we are facing is that all of these pills, Percocets, your oxycodone, OxyContin, are all being made with fentanyl. So if somebody wants these pills, now they're getting them, but they're made with fentanyl. That causes a problem. That is stage 4. Stage 5 is something you probably haven't seen yet, is liquefied fentanyl. All of these nasal atomizers that are being seen, now they're liquefying the fentanyl, and it's a safer way of using fentanyl. So that is where we're heading. Why is this happening? It's all economics. I don't want to delve too much into this, but one thing you got to look at is that 1 kilogram of fentanyl costs $3,000. That is the equivalent of 20 heroin kilograms. One costs $3,000, the other one costs $1.2 million, and the profit is all the same. So Why would you want to sell heroin? Not that I'm trying to tell you to sell fentanyl, but it is, the numbers don't lie. It's truly a moneymaker. So small operations, very difficult to detect, but the problem is that these fentanyl dealers cause a lot more deaths. So this is drug trafficking routes that you see through the Pan American highways and also the Caribbean Sea. This has completely changed now. It's coming in from China through UPS, Federal Express, and also United States Postal Service. They're going on the web, ordering these drugs, coming in through Mexico, Canada, sometimes directly here to the United States, and then it gets into a respective state. That dynamic right there has really turned law enforcement efforts on its head because these individuals are going on the web, ordering it. It gets into, comes to their doorstep, or their neighbors or some senior citizens a couple of doors away. They track it, get the stuff, and then they're going on the web, like this individual here who was selling, had a lab, pressing pills. This was his lab. And then he was shipping the drugs also through the United States Postal Service, selling it on the web through Bitcoin. And how can you interdict this individual? And yet he's out there selling these drugs. So looking at Canada, there's novel psychoactive substances. They sent me a list looking at what they have encountered, comparing their list to ours. Carfentanil is something that's of concern to us. Anyone have carfentanil in their state? Real killer, right? It's just devastating what it's doing out there, especially out in the Ohio area. It is actually a tranquilizer for elephants. So it's a painkiller for elephants, and this is what their drug dealers are selling to people. So this is a deadly dose of heroin compared to a deadly dose of fentanyl. And that's a deadly dose of carfentanil. This is really potent stuff. It's actually classified as a chemical weapon. So the dealers realize this, and you're seeing less and less heroin involved in these deaths. And you see, this is actual toxicology result information. You see fentanyl and acetylfentanyl involved in all of these deaths. And we also see it through the crime forensic labs, where the one in green there, it had heroin, cocaine, and fentanyl. These are not polydrug users. This is what they're buying in the streets, and it's all combined. The rest is all acetylfentanyl. Here you see one beautiful thing about the labs is that they send us the primary drug, secondary, tertiary drug, and whatever order they're in, they send us this information. So when heroin is the primary drug, you see the fatal overdoses. Here, non-fatal overdoses, and then also the seizures by law enforcement. We track all of them. When fentanyl is the primary drug, you could see the death toll there on the number of fatalities. This information is quite critical for us because it helps us with emergency scheduling to ensure that these drugs, when people are found in possession of them, that they are able to be prosecuted. Why is it so important to identify these drugs? Well, in New Jersey, whenever or anywhere, you find a person dead with the drugs right next to them. You see that the drugs go to the crime forensic lab, the body goes to the medical examiner's office, but oftentimes there isn't a match because they don't go to the full extent of identifying what drugs were in the system. So we're using this data to connect all of the arrests, fatal and non-fatal overdoses, setting up biosurveillance for naloxone deployment, and also using now image trends to help us identify where those spikes of overdoses are occurring, and just seeing how different counties are trending as far as naloxone deployments throughout the state. One critical methodology that we use using ESRI here is that you can't just look at where a heroin seizure occurred, but look at where individuals come from to go arrested. So that journey to drugs becomes really important because those people may be coming from a low crime area, but they're going to those urban centers to be arrested. So extracting that data becomes really important. This is just a sample of all of the different products that we produce, one of them being the drug harm index. We catalog every single incident, whether it's a drug submission, fentanyl, a death, naloxone deployment. That enables us to rank the counties. We're looking also to grow this to include shootings, deaths, NAS, HIV, and also hepatitis. We're able to rank all of the different counties to see which areas are worst impacted, ranking them by the different individual harms, fentanyl, drug deaths, all of the categories, sheer numbers, and then looking at them per capita, and you see the difference in different states. And then we can drill down on the specific county and drill down looking at the different age ranges that are people being arrested, the different drugs that are being seized, naloxone deployments by month, time of day, day of week, ages, pills being seized. So I want to get down to the last slide, where you're able to look at where heroin is being seized, where fentanyl is being seized, and overlaying the health data, the naloxone deployments. So we go from the state down to the county, and now we get to at-risk populations, and then now to at-risk individuals. This is 2 naloxone reporting forms by law enforcement. This lady received naloxone 2 times within 2 hours, right? These are the people that are most at risk for dying. So what I did last year was I took 4 years worth of data for people being arrested for drugs and also for thefts, and came up with 6 million records and identified 250,000 individuals. So we have all of those names. As those people receive naloxone, we're running those names to see which individuals are most likely to overdose or be arrested for some type of drug-related crime. Those are the individuals that we're targeting to get them into, not jail, but to get them into treatment. So this is really a proactive way of helping our human services identify these at-risk individuals, introduce them to drug recovery coaches to get them into treatment. And how do we know that we're being successful? It's just looking at all the different harms, looking at the outputs, not looking at the outcomes, but then measuring the impact that we're having to see if those different harms are increasing or decreasing. And then you can evaluate if your programs are being successful or not. And that's it for my presentation. Thank you for your time and attention. Doctor?
I'm going to start off with questions. Okay. So, and then we'll open it up. Given that you've been doing this for a while, how have you engaged either at the statewide or at some of the local cities, the health communities and other folks to partner, and what do you consider your best success in terms of pulling together some of the different players and the data systems for being able to move things forward?
Sure. So our first success was establishing that relationship with the crime labs, and then reaching out to the Department of Health. But as word got out, going out to the prevention coalitions and the municipal alliances, those folks involved on the local level were the ones who really valued this information, because they were getting real-time data to develop their needs assessments, and they swear by it, and whether they're writing for grants or creating budgets, they use this data to make decisions. And also law enforcement, whenever there's a death and they need the investigative support, we're providing them lead information, because we're able to use the forensics to identify who the potential dealer or where the area may be.
Questions from the audience?
Captain, a couple of questions. Bill Hazel from Virginia. First question is, how long does it take to turn around the tox screens for your state labs? How quickly are you getting those? That's one question. The second question is, what information would you like to have that you can't get? And then the third question is because I couldn't see.
Let me get my pen out.
From way back here is, You know, if you were to ask your 3 deliverables that demonstrated this was useful, tell me what they are. If I couldn't read the slide, but if you were going to the legislature saying you needed more money for this program, what would you tell them that you've accomplished besides getting a lot of data?
Sure. So our labs, the backlog was about a week when we first started, but with the introduction of fentanyl and now identifying all of these derivatives through the mass spectrometer, they didn't have all the standards, so they had to do a lot of research, and that created a backlog. So we've gone, the number of seizures have gone on significantly, and now they're somewhere about a month and a half. But whenever we have a spike of overdoses and we have a testable specimen, and we ask them to expedite or prioritize a specific specimen, we have it turned around in about 2 hours. And your second question?
The issue is what data would you like to have that you can't get?
So we could go into the whole HIPAA issue. If we have approximately 25,000 naloxone administrations right now, and approximately 8,000 are by law enforcement. We have the personal identifying information for those administrations, but the other 17,000, we can't have access to it. So if we were able to access that data, we can take those individuals, run them against the matrix, and get a true number of the individuals who are most at risk for overdosing to get them into treatment. So that is one. And you know, another thing I would like to see with that data, with the naloxone deployment, is that the doctors that are prescribing drugs to individuals, that they're able to look into PDMP, but then also look at who has received naloxone, because that's an indicator of somebody that may be misusing drugs. So PDMP is good, but then the naloxone data, I think it's more of a solidifier of substance abuse. You have one more?
So this is your New Jersey legislature here, and you need $10 million more for your program. What are the 3 or 4 things you can tell us that have been positive as a result of this? You got all this data, you've wired it up.
Right.
What have you actually accomplished?
So what we have accomplished is giving everyone in New Jersey an awareness of the presence and prevalence of drugs in specific areas and specific demographics that are being affected. And we're really influencing policy across the board, whether you're in prevention, treatment, or recovery. We're helping, or even law enforcement, we're helping influence decision-making across the board. And whether it's grants that people are writing for, they're writing budgets, we're constantly getting pinged by the governor's office, the attorney general's office, down to maybe a school district that's looking for data. We're able to provide them this information. So right now, my wish, my utopian view of the whole thing, how I think things should be, is that all the data that we have we should have an automated workflow that cleanses, normalizes this data and goes into a central repository that you would have access to it based on your role, this role-based access. So if you're HIPAA protected, you would be able, HIPAA covered, you'll be able to see the data. But then if you're law enforcement, you can see law enforcement data. But then you're able to see de-identified versions of both data sets to help you understand or look at things across the 2 different disciplines. And one thing is that all of the different reports that we push out, we found a way of desensitizing HIPAA-protected information and also law enforcement sensitive information. So like this, there's understanding from both sides. And we can do the same thing through a dashboard. So when you're giving me my $10 million, huh? Come on.
Do you have an estimate of how many people you've been able to divert into treatment pre-overdose that you've identified is 1, and 2, how are you desensitizing the information so that you can identify these folks?
Okay, so to your first question, because we're so into the data and everything that we do as far as intelligence production and fulfilling those requests for information. We don't dig down into the specific programs in their outputs. Right now, what you're seeing with this drug harm index, we're looking at more the law enforcement results, more so than the public health or human services results. So I don't have a number that I can share for you. And your second question, I'm sorry, I have a short-term memory.
How are you desensitizing the data? How are you able to, so that you can identify these people for referral?
Sure. So anything that's personal identifying on the law enforcement side, as long as we're not exposing any individuals, cases, or methods of intelligence gathering, on the law enforcement side, we're good. We have specific data elements that we receive from the Department of Health, and we can aggregate up to the zip code level, 5 or more, to ensure that we're not drilling down on one specific incident where the person could be re-identified because it's such a small location. So it's something, I don't want to get into the whole explanation here, but we're able to use this data in an aggregate manner and distill it down to something that's usable across the two different disciplines. So to us, what we receive is already de-identified on the health side. Our biggest challenge is on the law enforcement side to make sure that we're not exposing the individuals or the investigations.
Hi, I'm an IT guy.
Okay.
Over here. Can you comment a little on the size of your IT staff, sort of before and after? I mean, what kind of staff has it taken to accomplish this?
I don't have any IT people, and I could tell you that the magic sauce to this whole thing was really leveraging the existing people, platforms, and processes. And everything I was able to do here, $0. It was just getting people together to work together. That's pretty much what it was. But as far as the data cleansing and normalizing and all this other stuff that goes on, we have the Department of Health, we have Human Services, the National Guard. They all contributed personnel to create a staff.
So do you have any sense of what the sort of sum of that is in FTEs? And obviously folks aren't doing something else if they're doing this. So even if you didn't get additional staff, someone's not doing something they were doing before.
Right. I don't have a cost estimate on what the salaries are for those individuals.
Oh, what about just sort of a sense of how many people you think are?
How many people?
Sort of
11.
Okay.
11 people.
That's something.
Yes.
Thanks.
And they all vary in salary. Oh, the one piece of technology that we have now is SPSS. So other than that, our database right now is still an Access database, nothing fancy.
So when I do a credit card, it doesn't get posted in 2 hours. I mean, I go on my bank, and we have people that are buying the drugs don't know what's in the drugs. We may have 40 overdoses come up within an 8 or 9 hour period in a very limited period of time, and the people that are the people that are doing the treating may not know it because they're not doing this. They just know what's happening in my emergency department. So getting this information, I mean, obviously there's bigger issues and how do you change prescriptions and other things, but we have something going on that's killing people. And it's killing people in clusters because somebody, doesn't idiosyncratic, it's not the only person who bought the drug. It's not, they're not doing personal drug prescriptions. So I think the fact that, just as an example, there's many other things you need to do, but the fact that you were rapidly able to get the assessments done when something is coming into a neighborhood that looks like there's something spiking there, to be able to change the information so even the consumers can, because the word gets out, but it doesn't necessarily get instantaneously. And so, again, measuring what your life saving is going to be very difficult, but just knowing how this works, the fact that you got the information that there's something in there, and specifically what's in there that people don't realize is in there, may get them to hesitate a little bit or have somebody next to them when they're injecting because they're worried about what's going on. And so I think there's some of this that we're talking about, we really do need we have the capacity, but you really do need rapid information going there. It's, even within a week or two, we can be talking about hundreds of lives.
Just one more comment. The number of incidents occurring gives you one thing, or gives you one piece of the puzzle, but the number of naloxone deployments per incident, because we have had up to 8 and 9 deployments to the same individual just because they're trying to revive them. That tells you that something really potent is being sold out there. So if they tell us that it was the Batman stamp that was involved, we can look in the database and be able to tell that, yeah, it was velorofentanil, if it was, acrofentanil, and that helps the ER or the emergency room know what kind of influx they're going to be anticipating, and also EMS in the area, how many naloxone deployments they may be using per patient that they'll be encountering. Someone else had a question? Yes?
Yeah, Paul Wormley. I want to commend you for the whole report, but I want everybody to know that you're being a little bit modest, Juan, in talking about the accomplishments of the New Jersey Fusion Center, which is arguably one of the finest in the country, and you have the advantage of having a superintendent of the state police in New Jersey who agrees that the war on drugs is over and we lost, and the answer is treatment, not more arrests, which is an enlightened view of Superintendent Fuentes in New Jersey. But what I think everybody needs to know is that this program that you've just described so eloquently has been an award winner amongst fusion centers throughout the country and is being modeled by many other fusion centers. So in your state, if you have a fusion center that's all inclined to do this, New Jersey has offered repeatedly to share the approach and procedures that they've used to create this bipartisan relationship between the health community and law enforcement in a much more enlightened way than has normally been done in our history. So I think this is something that's replicatable throughout every state in the country that has a fusion center that's up and running and operational.
Yes, sir. Thank you.
I want to thank Juan for that, and I want to just build on Paul's comment there. When we first met Juan and talked to Superintendent Fuentes and some other folks in the Fusion Center world, one of the things that became clear was the real strong interest in connecting to public health and human services, which I think is something you just sort of threw out there as though it was common practice across everywhere, which we know is probably not that developed. So one of the exciting things that we've learned so far coming into this is that there's a real interest in partnering with the health and the human services departments and agencies across the country. And so from the coordinator from the Northern California, who kind of oversees many of the fusion centers, there's a very strong outreach to say, okay, let's talk about how do we sort of build out, share the knowledge more aggressively across the country, and look for ways to connect to public health so that we can actually accelerate this effort. So it's part of, as we talk about the collaborative, there's a lot of interest in that from the Fusion Center world and the HIDAs across the country to really accelerate that work, build out what they've done in New Jersey and other places, and make that available. And I think that's one of the things we want to try to connect the dots on, because it's a well-kept secret in the human services space, probably not in the policing space, the work you're doing there. But one of the things we want to do is try to build that out.